Okay, so I would like to thank all of our speakers for their presentations, and we will now open up the question and answer period. I would suggest that perhaps we start with Dr. Addo and bring up some questions surrounding the vaccines. And if I might, while the questions are coming, and I think some of them correlate with me, what is the current state of knowledge around the effectiveness of people living with HIV with the various vaccines? And are we coming any closer to understand what the correlates of immunity are?
Well, hello, everybody, and thank you, Sharon, for that question. So this is a very important questions that you raised. Coming to your first question about studies or data on people living with HIV and COVID-19 vaccination, there are several studies out there that address especially this topic. And there was one publication that was just released in April that looked at people living with HIV at different strata of CD4 counts, and these individuals were vaccinated with mRNA vaccines, and it was seen that there was good safety profile and there was good immunogenicity, like with other vaccines that we know in people living with HIV. If you have low CD4 counts, and so they're certified to less than 200 and 200 to 500, so the lowest immunogenicity was seen, not surprisingly, in this lowest CD4 strata count, but above 500, the vaccine responses were actually as high in terms of antibodies and T cells as in not HIV infected individuals. So this is all good news. Coming to your second questions about correlates of protection, this is an ongoing topic, and so there's data out there, also modeling data out there from different vaccines that show that neutralizing antibodies do correlate quite well with efficacy. If that is really the mediating factor, or if it's something like non-neutralizing activity that we're not measuring as systematically at this point in time, or even T-cell activity, this is still not 100% elucidated. Maybe I'll stop here for the moment.
So I think there was a question from Dr. Sergides about whether the mRNA vaccines elicit CTL activity.
Yes. So in fact, what is measured, that's been measured so far, has been T-cell responses with different means of measuring them, either by elicit or by interferon gamma release assays, EGRAS, that are similar to what we use in TB diagnostics. And in fact, yes, mRNA vaccines also elicit these responses. And we feel also that there's data out there that show, especially in light of the variants that we're seeing now, that T-cell responses seem to be less susceptible to immune escape compared to the antibody responses. And so it actually might be an important factor to maintain vaccine efficacy and the prevention of serious disease causes and death. So yes, they do elicit T-cell responses. The question is, are these T-cell responses durable? And so the debate is ongoing if either heterologous vaccination, combination of vector vaccines and mRNA, or also vector vaccines that are probably felt to be more targeted towards T-cell responses, if that is actually the case. But yes, they do induce them, and they do, as I mentioned in the CID paper that came out in April, they also induce T-cell responses in people living with HIV.
I think there's keeping with Dr. Addo, what are the sex differences? This is from Dr. Hankins, sex differences in response to vaccine. Then maybe if you want to add into any comment there.
This is actually a very fascinating research topic, sex differences in immunity, but then also sex differences in vaccines. And we know from other vaccines, and I think one of the most striking examples is flu vaccination. There was a large study with over 1,000 individuals, where it was seen that in women and men, if you compared people between 19 and less than 50, that you could use half the dose of flu vaccine in women and still elicit the same or higher immune responses compared to men. So these signals have been seen and studied by a colleague, Sabra Klein, in the US very extensively over the years, and the most data we have on flu vaccination. I'm sure that these data will be, this aspect will be looked at more specifically in the context of COVID vaccines, but I'm not aware of any published data at this point in time that already sees antibodies being higher or efficacy being higher. So we don't know that. But the topic of sex differences in immunity is important because, in fact, the immune cells have estrogen receptors, or like hormone receptors. So it is logical that there also can be differences in biological outcome. And we know that there's a difference between females and males in HIV, which is a signal that we've known for a long time. So I'll stop here. Thank you for that question.
So Marilyn, we've been doing a study in the general elderly population, so not people infected with HIV. We've been looking at antibody levels through dried blood spots. So we can only measure antibody. We can't measure neutralizing antibody, but we're measuring antibody to RBD. And we did find our women, the older women, had a better immune response than men. But we had some other factors, and body weight was one of it. And unlike disease, people with high BMIs were doing worse. In our vaccine study, people with low BMIs did worse, and perhaps an indication of frailty, I don't know. But our women did have bigger immune response than the men. We don't know what that means. Yeah.
That's very interesting, because some of the studies in the it's a very complex topic and a very interesting one, because some studies actually show that this effect of higher immunity in women actually gets lost after menopause. So the data that you're sharing there is very interesting, because it doesn't go with that. It doesn't seem to go with this hypothesis, but obviously there are many factors that might need to be looked at. But I think we have to, in the future, COVID, HIV, you name it, we have to kind of take the topic of sex differences much more seriously and go towards more individualized therapies, because we've known in the HIV field, we have kind of oftentimes said one size fits all, and we have seen very detrimental effects, be it like with nucleoside analogs in the old days. And so I think we have to kind of, and it could also like help us save vaccine doses if we need half the amount of vaccine in women, like, which was the outcome of the study that I just quoted, that in the context of a flu pandemic and shortage of vaccine, one could actually reduce the vaccine dose. That was kind of why they pursued this study. So a very interesting finding, also what you found with differences in BMI.
And the Canadian HIV Trials Network is currently doing a study in HIV, and we tried to heavily weight it with women, to look both at antibody and T-cell mediated immunity to try and sort out some of those factors. And I think, as you pointed out, much of the data in HIV has been done in people with well-controlled HIV and good preserved T counts. And what we're really faced with in the clinic is those patients who are maybe immune non-responders or discordant or whatever in making advice about vaccines and boosters.
And these individuals also give us the hardest problems when we treat COVID infections. So like we really have to focus and understand better what's going on there and see how we can protect them or find strategies to keep them safe, and what's the best schedule like vaccines regimen for individuals such as those that you described. That's true.
I think there was a comment from Brian, since we're live. I don't know if you want to actually talk about it. It's a great topic to segue into about pregnancy and all these studies. So
yeah, so I don't know how you what the experiences had been in counseling pregnant women about vaccination. There's been a lot of hesitancy to get vaccinated, and it's probably understandable by women who are insecure about what is good for the baby and what's not. Like there's very clear data for influenza that women are actually a population that has to be vaccinated because they are at highest risk. And these data are emerging, probably not as dramatically, but very strong signal, especially with a lot of the data that come from Canada and the US, that there are poor outcomes of COVID infection in pregnant women. And I've actually seen a mother who just gave birth to the fourth child and an emergency C-section die from COVID. And these are like really such tragic cases that are so preventable. And if you then now see the data that has been emerging all over the world, it really shows very good safety signals for COVID vaccination in pregnancy with mRNA vaccines. And the data that I showed you on high antibody levels in the infants born to vaccinated mothers should give an extra kind of motivation to really encourage our patients to take up this offer for their own protection, but also for the protection of their children.
I think we're
so perhaps
out of arrest. We're moved to. We got a question finally. We'll give you a rest now. This is a great question. So, what will it take to make genital schistosomiasis treatment part of combination HIV prevention?
Oh, I think that's a great question. So, in terms of treatment of urogenital schistosomiasis, the WHO does recommend mass drug administration for children, and they are recommending treatment of adult women with either schisto-infection or actually established FGS. Coverage is incredibly low throughout sub-Saharan Africa, as you can imagine. Coverage in children is quite a bit higher. But in terms of the integrating that schisto detection and then treatment for FGS, because FGS is the risk factor, right? It's the lesions and the granulomas, the manifestation of having schisto that is the risk factor. So integrating that into HIV care is going to be tricky without, good screening algorithms and diagnostics. And again, the current diagnostic is the gold standard is colposcopy, which is very expensive. There is some argument for let's just do mass drug administration in adult women, and of course that gets rid of the eggs. But then the big question that our group and others are now looking at is this question of lesion resolution post-treatment in adults, because people have seen that if you're treating younger women with praziquantel, their lesions do resolve. And again, the lesions are the risk factor for HIV transmission. There are some data that indicate that perhaps older women or women with more advanced lesions won't see resolution post-treatment. And so that's a real problem. So there are some groups that are talking about, well, is the current treatment regimen sufficient? Do we need to add an anti-inflammatory or another antifibrotic, because the praziquantel does have antifibrotic properties? But there's certainly a group of women, it seems, that even if they're treated, we're still, not treating them sufficiently, which would certainly have, which would certainly impact the HIV prevention you're getting out of treating FGS.
So, Kristen, I wanted to add to that, and what is the thought to be the risk factor for the increased transmission? Is it the actual ulcer? Is it inflammation associated with ulcer? Is it more CD4 receptors in the ulcer? What is thinking?
Another great question. So there are some preclinical studies looking at mechanism, and there are several hypotheses, and there are different hypotheses for FGS increasing your risk of acquisition of HIV if you're negative versus the potential mechanism for increasing onward transmission if you're living with HIV. And in terms of increasing onward transmission, some studies have seen that having FGS, these established lesions, is associated with an increase in recruitment of HIV of a higher viral load in the genitalia, seen in men and women, men with urogenital schisto. And then in terms of the acquisition, There's some discussion of disruption of the microbiota, disruption of the epithelial barrier, those sorts of things, just increasing acquisition risk. But that is also an area of active research, that people are not sure what that mechanism is.
Great.
We actually have two questions now related to underrepresentation of specifically females. So the first one is from Shada Swan. It says, thank you for these great talks to everyone. But the specific question is, we often see in our clinic that women have more ARV side effects than men. Do you think this may be associated with women being underrepresented in clinical trials, but taking the same doses as women? Great question.
Yeah, that is a great question. I think it speaks to a lot of the conversation we've been having so far. I should say I'm not a medical doctor, so I can't speak to that side of the question, but I will say that the question is raising an important point about underrepresentation, broadly speaking. If women are underrepresented in HIV research, which women are certainly underrepresented at various phases of life as well, at various ages, during pregnancy, outside of pregnancy, the perinatal timeframe, breastfeeding, menstruation, all these different time points. If women are underrepresented in all of these areas, and broadly speaking, we'll certainly have less information about the safety, the efficacy, the side effect profile of compounds, drugs, interventions in this population. So I think it's an important point to be raised, and we can speak to other consequences as well. One that I sort of mentioned during my recorded presentation is interventions not being able to be approved for populations. We have the Descovy as PrEP example as a prime one. If I were to say, Descovy as PrEP has been studied in women, of course, we would all agree that is not true. And this is why the FDA in the United States has not been able to approve Descovy as PrEP for cisgender women, because this population was excluded from the initial trial. It's my understanding that there's a current trial going on. But I want to also point out the language that I've used here. If I were to say Descovy as PrEP has been studied in women, we would all agree that this is not true. However, that's actually not the full story. Descovy as PrEP has been studied in transgender women. And so I think we also need to pay attention to the language that we use and to make sure that it reflects the accuracy of the science, that we're maintaining scientific integrity in our language. If we were to flip what I've just said and say that cabotegravir, long-acting injectable cabotegravir as PrEP, has been studied in men, I think most people would agree that this is true. It's been studied in cisgender men who have sex with men, but it has not been studied in all men. It has not been studied in transgender men, the same way that Descovy as PrEP has not been studied in all women, only a subset of women. So again, I think we need to pay attention to the language that we use and make sure that when we're studying interventions, compounds, drugs, that we're asking the question of who is included in the trial, who is included in the statistical plan, to make sure that these interventions can be utilized by those who truly need them most.
Yeah, I think you hit the nail. We had a meeting this morning, and Liz Barrick, she spoke to us for the Women's Scientific Collaborative Group, and this was one of the things about we analyzed data from both the 2018 and 19 CROI, and there was totally a missing up of sex versus gender, and so it really needs to be obviously ironed out. I think the last question is all we probably have time for. It comes from Dawn Averett. Again, to you, Brian. It says, have you had any luck in the networks modifying, and again, bells ring up because this is really the things for me, that is a significant barrier, modifying the standard protocol language of women of childbearing potential, contraception requirement that often serves as barriers for diverse representation in studies. Amazing.
Yeah, fantastic question. We're in the midst of this process. So this, when I presented the representative studies rubric, this is now a rubric that is being implemented by all four of the research networks: the AIDS Clinical Trials Group, IMPACT, HPTN, HIV Prevention Trials Network, and HIV Vaccine Trials Network. So one place we've started is actually the protocol templates. In the HVTN, for example, HIV Vaccine Trials Network, they use a standard template for their phase 1 and phase 2 trials. So we've gone through and actually started to edit the language that's in there because it gets reproduced. Everybody starts with the same template, but if we can start there and edit some of the language, that's one way that we've begun. But also these 12 questions that are included on this study rubric, and I believe the link has been shared as well to see the full language of these 12 questions. We're now implementing a process where every protocol in the 4 networks will be asked these 12 questions. The protocol development managers will ask the 12 questions when developing the study. So that way, at least a conversation can be initiated about pregnancy, for example. Do we need to be excluding all persons who can become pregnant? Do we need to require contraception? So at least the conversation will be initiated during the protocol development process.
Okay, and Kasima, perhaps a couple of questions for you before we close out here. Very disturbing data on the frequency of trauma. In your project, did you explore the source of the violence for these young people?
Unfortunately, we did not. Our data was limited to just the outcome in terms of utilization of those services. So we were limited to that sort of sphere of data, but I'm sure that's also a rich area of exploration in terms of, especially within the COVID-19 pandemic and the various challenges that presented.
Yeah, and I think, if you're going to intervene, it's kind of, who is the source of this trauma? Is it someone they knew? Is it someone they don't know? And particularly from the adolescent population, is that coming from family, from friends? Is it from each other? And why do you think the adolescents were more impacted during the pandemic than older people?
Yeah, it's a great question. I think this has sort of been explored. Also, there's a few reports about it, sort of naming it as a shadow pandemic, and that it sort of created this perfect storm with various pressures, whether that was isolation, economic pressure, school closures, especially for young people who are then required to be at home with relatives and other family members. Maybe various stresses and anxieties also led to increases of substance use, which also are directly correlated with increases in violence. So I think those are some of the factors that led to that, specifically for young people, especially with lower economic opportunities and also school closures.
Yeah, it's all very frightening, and I think you certainly have seen this in your setting, but I think it's not an unfamiliar story with all of our settings. And I come from a rich city, and my patients, those were the first few questions when we came back. Do you have food? Do you have a house? Did anyone hurt you? Which is really what we're all dealing with, and I think that a lot of HIV testing, certainly here, decreased during the pandemic, and we all worry there's going to be another wave now, another pandemic of HIV, as people have failed to be tested and treated throughout the last couple of years. Okay, so we're just about ready out of time here. Are there any other questions from our audience? Any of you on the panel have questions for anybody else? There's lots of references that have come forward in the chat for those of us to pick up. I think we could have talked about any of these topics, particularly COVID, for the next hour and a half, but we must move on. So at this point in time, we're going to have a virtual break, so you can all find your own bathroom and your own coffee. This is the time we usually have the ongoing discussion about the sessions, and that's the downside of a virtual meeting. So I welcome you all back at 12:50 Eastern Time, 6:50 p.m. those of you in Central Eastern Time, and we are going to further discuss the impact of COVID, not only on service delivery, but how this has impacted women clinicians and researchers over the last couple of years. So please come back in about 15, 20 minutes. Thank you.